Hi guys, I'm just making this short video on patellofemoral hypermobility. Now, to understand hypermobility of the patella, firstly you need to understand the factors that control patellofemoral mobility. Now, locally, the factors that control it are the height of the patella and the depth of the trochlea. Okay, and meaning if the patella is higher than where it normally should be, i.e. patella alta, then it sits in a more shallow part of the trochlea, which then makes it more vulnerable to mediolateral movement. Now, at the same time, if the trochlea is dysplastic, as in there is trochlear dysplasia, of which there are a couple of types, now that again can make the patella more mobile on a mediolateral plane. Now, the other factors that control patellofemoral mobility from a proximal perspective is the femur, and the femoral anteversion in particular has a potential to allow increased internal rotation of the femur, and that of course can increase the lateral patellofemoral joint contact, which of course can cause things like superolateral fat pad impingement and perpetuate one's patellofemoral pain. Of course, those were the osseous factors. Now we'll talk about the soft tissue factors, and that's primarily the quadriceps muscles, the medial patellofemoral ligament. Now, do understand that there are different aspects within the medial patellofemoral ligament. There's a very good article that was published a couple of months ago that details the anatomical extension of the medial patellofemoral ligament. I will quote that at the bottom of this video. Now, I come across lots of people who failed patellofemoral rehabilitation elsewhere. It's a special interest of mine, so I get referrals from other places to treat such patients. And often I do find that these are patients who in fact have hypermobility within the patellofemoral joint. Now, there is also an argument to call this patellofemoral instability, but as to whether or not we should be using that terminology, I'm not entirely sure, so I stick to patellofemoral hypermobility, which then means that there are ways and methods with which we can control that, either through means of controlling the femoral internal rotation, or by means of controlling the patellofemoral mobility by getting the quadriceps muscle stronger, by using methods such as taping or bracing, which you can use intermittently as and when you need, in this particular group of patients who have failed to rehabilitate as you would normally expect to rehabilitate. Finally, I will just show you my knee model, and I want you to guess what that little yellow thing is. Okay, well, it's a washing up sponge, and I can tell you that, but what does it actually represent? Okay,